Greeting from Paris. I'm Dr. Elie Azoulay from the St. Louis Hospital, and I have the privilege to present the COVID-19 infection in three specific subgroups, and I have taken the example of immunocompromised patients. I have no disclosure in relation with this presentation. This is a very important paper that has been published recently in Clinical Infectious Disease. This is a global cohort, and it just brings the importance and the prevalence of immunosuppression in patients with COVID that is surrounding 10% overall, mostly from patients who are with cancer, inflammatory disease, AIDS, solid organ transplantation, and bone marrow transplantation. The interesting thing in this study that was performed in the United States is that the immunocompromised status was not associated with mortality, and there was no association with the need and the use of ICU resources. Let's first take the example of transplantation. I mean solid organ transplant. As you know, these patients are immunocompromised not only from the comorbid condition, like example, chronic kidney disease or chronic liver disease, but also by the treatment that are taken to tolerate the transplant. This is a systematic review of cases that I found very interesting. The Dr. Musavi and colleagues have reported more than 330 patients from 50 studies. And of course, kidney is the first one to be represented, followed by heart and the liver. And the major difference is that patients who are recipients of SOT, solid organ transplantation, had more frequently gastrointestinal symptoms than other patients. And the mortality in these patients was 18.4%. There was no control, so we are going to look at other papers. The study that is presented here is a study from a French registry on COVID-19 patients in recipients of kidney transplant. As you can see, this is a study of 279 kidney transplant recipients, including 50 patients who are going to have an ICU need, either for mechanical ventilation or for another need. As you can see, severe disease, as characterized by the need for oxygen or any organ dysfunction, occurs in approximately 50% of the patients, and death is reported in up to 23% of the patients. Obesity, fever, and dyspnea were risk factors for severe disease, whereas age, cardiovascular comorbidity, and dyspnea were risk factors for death. Another French registry that has been published more recently this summer in ISICEM from Dr. Elias and colleagues from my hospital reported 66 patients in a global cohort of 1,216 kidney transplant, making 5% the need for ICU management in kidney transplants recipients, which is very high as compared to other studies. Independently associated with COVID-19 was the ethnicity, the body mass index, respiratory comorbidities, as well as diabetes. Again, the same proportion of death, with 24% of death in SOT recipients as compared to 1% in non-COVID patients who were also SOT recipients. In Germany, and this is here, heart transplants, the number of patients is of course lower because of the proportions of respective SOT. And you can see that severe course was reported in 1/3 of the patients who were intubated, but mortality was as high as 87%, making very clear that we are dealing with very, very vulnerable patients. Mostly when they are with kidney transplant, mortality is above 20%, but here we are above 85%, which is enormous. Here we are in a global cohort of patients who are SOT transplant, 98 patients compared to 288 non-SOT patients. Again, kidney, liver, heart, and lungs, which is normal. And you can see that the need for organ support and mortality were not different between the two groups, showing that there are biased studies provided by cohorts of organ, and when you are looking at the entire number of SOT recipients, the numbers are lower and the differences are harder to mention. In a small study of patients from my hospital who needed ICU for mostly kidney transplant, 10 among 106, you can see that mechanical ventilation was needed in 6 of the 10 patients, and that acute kidney injury was very prevalent, and mortality was 30%, which is in line with mortality that has been reported in kidney transplant recipients. This is a very striking paper that looks again at the entire cohort of solid organ transplant, and we can see that the lung transplantation is one of these that has been associated with higher mortality as compared, of course, not only to other transplant, but also to patients who are not transplanted. The second example with less paper published in the literature is about hematology patients. This is a paper published by an Italian group in the Lancet Hematology, and the number of patients is quite high with 536 patients, and you can see that 85% of the patients were hospitalized and 37% died, which is a very high proportion. Of course, when we compare the rates and mortality and case fatality in patients with COVID-19 and transplant as compared to the overall Italian population that was also very much affected by the COVID-19, you can see that when we are looking at the differences, 50 patients needed ICU admission. And if you look at the circles that are surrounding the triangles, you can see that the patients who are with solid transplant, hematological malignancies, always had a higher mortality than the global population. And this is presented here by age groups, showing that not only mortality increases with age, but mortality is always higher in the whole cohort, or in male and female, whatever the age, showing that mortality associated with hematological malignancies is very significant as compared to patients without malignancies. Interestingly, when we look at the reason why such morbidity appears, we have the vascular complications that are related to the comorbid conditions, infection, of course, that is mostly bacterial and fungal infection, and of course, the sensitivity and the specific organ damage, mostly from acute kidney injury and acute liver failure in respective patients. This is another paper that is very interested, coming also from Turkey and comparing hemato to non-hemato patients. As you can see, mortality is almost twice in hemato patients with 13.8%, which is lower than the Italian paper. And you can see that also severity is much more frequent in hemato patient as compared to non-hemato patient, which is in line with the higher needs of ICU admission and mechanical ventilation. And there's a very important systematic review that has been reported in all other malignancies. But before that, I didn't mention in this presentation all the papers on viral shedding in patients with T-cell defects, either from hematomalignancies or from solid organ transplantation, that had a prolonged shedding, explaining maybe why these patients have also a prolonged course of disease. So they are sicker, they make more severe forms, mortality is higher, but also the shedding is prolonged, making that these patients remain vulnerable for a longer time. I would like to finish this presentation on particular cases with a very interesting systematic review and meta-analysis published by Dr. El-Gohari in hemato-onco stem cell therapy just recently. Interestingly, about 1,000 cancer patients were reported in 22 studies, and the prevalence of cancer in the global amount of COVID-19 is 2.1%, which is slightly higher than the one that I reported initially, but this is coming from 22 studies. Mortality is in the same proportion, 21%, and we know that the severe cases are very high as compared to the global population, 45%, ICU admission is 14%, and mechanical ventilation is 11%. Interestingly, when we compare a non-cancer patient to a cancer patient, we can see that cancer patients have a higher risk for mortality, for severe forms of the disease and critical care illness, for ICU admission, as well as for mechanical ventilation. So overall, almost the same presentation, but it's always more severe with more ICU admission, more severe cases, more requests for mechanical ventilation, even if we don't control on the triage that has been performed according to studies, and unfortunately, a higher case fatality. Thank you very much for your attention.